Hello, welcome to the GAP MASLD MASH Community Network, sponsored by Madrigal. Today, I have the honor and privilege to review MASLD pharmacotherapy, and I'd like to thank the organizers of GAP and our sponsor for having this opportunity to speak to you today. Please use the QR code to record your attendance for this meeting. And we'll get started. My name is HoChong Gilles. I'm a nurse practitioner at the Central Virginia VA Healthcare System. And, we have, prior to March of 2024, the treatment and the management of MASH and MASLD really surrounded lifestyle modification and optimization of comorbidities. Its focus was to really manage the overarching metabolic syndrome, which is the main driver of MASLD and MASH. Approved therapies, as you can see, emphasize lifestyle changes and specifically weight loss. We observed the resolution of MASLD and MASH in about 80% of patients that were able to achieve about 10% of weight loss, but realistically, only a minority of patients were really truly able to maintain this level of weight loss. But until March 14, 2024, there were no therapies specifically indicated to address MASLD or MASH clinical endpoints until the approval of Resmetirom. So GLP receptor agonists, we have endogenous GLP-1, which stands for glucagon-like peptide 1. And after food ingestion, it stimulates glucose-dependent insulin secretion. It suppresses glucagon. Its side effect was also to delay gastric emptying, and it directly acted on the hypothalamus to promote satiety and reduce energy intake. So as you know, that GLP-1 receptor agonists are analogs of this gut-derived incretin hormone glucagon-like peptide 1, and they were truly groundbreaking. It helped many achieve weight loss goals, which not only improved patients' overall health, but also we saw improvement in fatty liver. GLP receptor agonist lowers blood glucose and results into weight loss. And as you can see, there are many drugs that have the same commercial, the same drug, but they have different commercial names because it depended on either the indication of diabetes or the management of obesity. So the role of GLP receptor agonists is a lot of the data is coming from the Essence trial, which explored semaglutide 2.4 milligrams a weekly injection, and it successfully met both primary histological endpoints at 72 weeks, showing the resolution, significant resolution of MASH without worsening fibrosis, and significant improvement in liver fibrosis without worsening steatohepatitis, which are, what are required by the FDA for approval. We can consider administering these GLP-1s especially for those that have, that are overweight, with a higher priority given to those with MASH or fibrosis, although not ideal for lean MASH. So how do GLP-1s affect us as GI providers? As you know, because of the side effects of gastric emptying, delayed gastric emptying, it also increases the risk of aspiration with anesthesia. So it is recommended that we actually hold their dose of a GLP-1, especially for those that are on the weekly injection, for 7 days prior to their scheduled endoscopy procedure due to the increased risk of aspiration with anesthesia. And if they don't hold the medications, unfortunately, a lot of the endoscopies are being canceled. So vitamin E is a medication that, based on the landmark study of the PIVN trial, showed that vitamin E improved some liver histology in non-diabetic adults. The premise was that the mechanism of action in vitamin E can improve fatty liver primarily due to its antioxidant properties. Vitamin E reduced oxidative stress in liver cells. It decreased the production of pro-inflammatory cytokines by inhibiting the oxidation of lipids in cell membranes. It also enhanced insulin signaling, reducing fat accumulation, and they could suppress the activation of these cells, reducing fibrosis that can also help influence genes involved in lipid metabolism and inflammation. In 2023, the ASLD guidelines suggested there was an opportunity opportunity of using vitamin E in select patients with NASH, MASH in non-diabetic individuals. However, our EASL counterparts did not recommend using high-dose vitamin E due to long-term risks of vitamin E, and also the concerns of, not meeting huge statistical endpoints. And there was also concerns about increased bleeding and prostate cancer. Pioglitazone was also on the PIVOT trial, showed that there was unfortunately no benefit of pioglitazone over placebo for the primary outcome improvement in histologic features in MASH. However, there was some benefits that were observed in some of those outcomes, especially reducing their cardiovascular risk. There were, safety considerations, and, pioglitazone is used today, but again, it just didn't meet the statistical endpoints of improvement or resolution of MASH. As stated before, on March 14, 2024, Resmetirom received FDA approval in conjunction with diet and exercise for the treatment of non-cirrhotic, non-alcoholic steatohepatitis, or MASH, with a moderate to advanced fibrosis, defined as fibrosis stage 2 to 3. It is a thyroid hormone receptor beta agonist, which selectively binds to and activates the thyroid hormone receptor beta in the liver. The production of thyroid hormone is actually regulated by the hypothalamic and the pituitary activity through the thyroid stimulating hormone, as we know. Thyroid hormone regulated many metabolic activities in several systems in the body, including the liver. We know mainly the thyroid hormone receptor alpha, but the beta is the isoform that is predominant in the liver. Resmetirom is a thyroid hormone beta receptor agonist that selectively targets the liver. Its key mechanism is treating MASH, which includes lipid metabolism. As you can see, resmetirom activates the thyroid hormone receptor beta in hepatocytes, which causes the upregulation of genes involved in fatty acid oxidation and lipid metabolism that helps break down excess of intrahepatic fat. It also increases the expression of bile acid synthesis, promoting cholesterol conversion to bile acids, and which enhances the efflux or exit of cholesterol from the liver. Resmetirom increases mitochondrial biogenesis and removes unhealthy mitochondria, leading to increased capacity to metabolize free fatty acids. By reducing intrahepatic fat, it directly decreases the inflammation associated with MASH and has antifibrotic properties because it reduces liver fibrosis by decreasing hepatic stellate cells, which are responsible for collagen deposition and resulting fibrosis. The FDA approved resmetirom under the accelerated approval pathway allows for earlier approval of drugs that treat serious condition, and it can also address an unmet medical need based on surrogate or intermediate clinical endpoints that reasonably predict clinical benefit. As you can see, the MAESTRO-NASH was this trial that led to the accelerated approval, and it was studied in adults with biopsy-confirmed MASH and fibrosis stage of F1B, F2, or F3. Non-cirrhotics were excluded from the study. And as you can see, they met the two primary endpoints at 52 weeks. However, they are required, and the study is ongoing, and will be assessing if the clinical benefit is still there after 54 months of resmetirom treatment. In this study, diarrhea and nausea were the most frequent side effects with resmetirom compared to those with placebo. However, the incidence of serious adverse events were actually similar across all trial groups. It was a randomized, a 1-to-1 to placebo, resmetirom 80 and versus 100 milligrams, and essentially there were no serious, there were no significant adverse events that was predominant in one treatment group. And as you can also see, the resolution of steatohepatitis, and you had to actually have a resolution of NASH with no worsening fibrosis. And also you had to see fibrosis improvement with no worsening of steatohepatitis. So Resmetirom 80 milligrams and 100 milligrams, as you can see, compared to placebo, was superior in NASH or MASH resolution and improvement of liver fibrosis by at least one stage. And it was clinically significant in those that were randomized to the 80 or and the 100 milligram treatment arms. And for practical considerations for managing MASH with resmetirom, it's ideal for patients, again, that is non-cirrhotic, and for those with moderate to advanced fibrosis, and which is defined as stage 2 fibrosis, stage 2 or 3. And it's and remember, we cannot forget that it is approved in conjunction with diet and exercise, which is still the cornerstone of MASH therapy. There are practical drug-to-drug interactions when using resmetirom. It's, you want to avoid medications that are strong CYP2C8 and or the OATP 1B1 or OATP 1B3 inhibitors. And I think the most important ones are probably cyclosporin and clarithromycin. Most protease inhibitors have multiple drug-to-drug interactions and should consult a pharmacist. However, because patients, a lot of them have cardiovascular disease, many patients are on Plavix or clopidogrel, and but you can manage people on clopidogrel, but you do have to reduce the resmetirom. And then there are also medications that can increase the exposure due to resmetirom. I think Pioglitazone, although it's not often used, and then of course montelukast, which is used for allergies and asthma. And that's commonly seen on, people's drug list. However, the statins is a big issue. It can be used. However, these are the dose limits, maximum doses that are allowed when using resmetirom. So for pravastatin and atorvastatin, you can't use more or exceed 40 milligrams. And then simvastatin or rosuvastatin, the maximum dose is 20 milligrams. There are practical considerations for managing MASH with resmetirom. There's ongoing evaluation with the 54-month extension trial for Maestro-NASH. We will likely need to think about restaging fibrosis or assessing steatosis with using non-invasive testing, using VCTE like FibroScan or PDFF or CAP to assess steatosis or the enhanced liver fibrosis, the ELF score, if you don't have access to FibroScan to assess or restage for fibrosis. Expert panels are still working on cutoffs and the frequency of testing that's needed for those that are on resmetirom. But the real practical consideration for managing MASH is, the widespread use will depend on insurance coverage. That is a barrier and requires often pre-authorization. There is no liver biopsy requirement, however. We don't really know the ideal frequency for staging or restaging and lab tests for monitoring. But, we all know that patients on therapy should be monitored for safety. But we don't really know the ideal recommended. So it's up to, the healthcare provider. Often patients are seen every 3 to 6 months, depending on their symptoms and their labs. Now, there is also no consensus right now on the duration of treatment considerations and also when to discontinue treatment if there are futility aspects, if they're not responding. And but the good news is that we have multiple agents that are currently in clinical trials and we will definitely have more options in the near future. So I just, want to thank you, but also to, remind folks to visit the GAP MASLD MASH Community Network to view the MASH disease state education and Rezdiffra promotional programs. They're really a great resource for additional information. And so that concludes the program, and I'll entertain any questions. Again, thank you so much for your participation, and see you soon.